Hi, I'm Bijal Shah from the Moffitt Cancer Center here at ASH25. Here to share my poster. This is a trials in progress poster. This is a trial of brexu-cel for MRD-positive acute lymphoblastic leukemia after induction. So the goal here is, as the schema shows, the inductions, which are pre-specified. We didn't want people getting low-intensity therapy. We wanted things that are, I think, common to ALL, hyper-CVAD, or mini-CVD with inotuzumab, Dana-Farber protocols for elderly patients, and so on. We wanted to make sure that those inductions were standardized and of sufficient intensity. If we were seeing MRD after that induction using the adaptive clonoSEQ platform, patients were eligible to move to the brexu-cel consolidation. For those who have high level of MRD, we do allow vincristine and dexamethasone bridging, and for the rest, we just observed them during the manufacture until they made it to the infusion. You can see here, these are the patients that we enrolled. There is no upper age limit, so median age was 53 for this cohort. Looking at the distribution of molecular subtypes, perhaps not surprisingly, uniformly high risk. So, I think this is one of these where I even surprised myself a little bit. I thought I would see some standard risk patients in here, but by and large, these were high risk patients. One of the things that we learned is that just between the time of enrollment to the study, then they apheresis to collect the T cells, we manufacture T cells, to the point of getting infused, we saw progression that was actually quite pronounced in some of the patients. So while our goal was to treat MRD positive patients, in reality, by the time they made it to the infusion, we were seeing some with blasts as high as 90%. And I think that's what really informs the conclusions. I think we probably need to be a little bit more uniform with our bridging strategy, so for all comers, not just for those who had higher levels of MRD going after their initial induction therapy. And we may even need to be creative now. We're starting to see these very short courses of blinatumomab, really running only about 2 weeks, generating potent remissions, and so maybe we need to think about an alternative lymphodepletion approach. All things that we're working on to try and help make this trial a little bit better. Again, very, very exciting data. I can't share with you anything as it relates to the outcomes, the relapses, because we haven't hit our pre-specified event rates. But one day when we do, I look forward to celebrating the data with the world. That's about it.